Welcome to the Ultimate Dental Podcast, the place where you can learn how to create a dental practice and a business life that you love. Listen in with Dr. David Moffet as he interviews successful entrepreneurs and successful business people and successful dentists as they share their business successes, their stories, and their breakthrough ideas, sharing pearls of wisdom that you can take back to your practice and implement immediately so that you can have that great practice with more patients, higher profits, and less stress. This is the podcast where great dental practices meet with successful business processes. Thanks for tuning in to the Ultimate Dental Podcast, the podcast where thought leaders, industry experts, and thriving practice owners reveal their very best tips, tools, and strategies that will help you grow your dental practice faster. Now, here's your host, Dr. David Moffet.
Hi, everybody, and welcome to today's episode of the Ultimate Dental Podcast. I'm your host, Dr. David Moffet. I'm in Burrawang in New South Wales in Australia. It is 19 minutes after 10 on a Friday morning. It gives me great pleasure to welcome to the studio, to the Ultimate Dental Podcast studio, Dr. Jeremy Krell, who's in Manhattan in New York, where it is Thursday night, Jeremy, about 8 o'clock, 20 past 8 over there. Is that correct?
That's correct. And thank you so much for having me. It's my pleasure to be here.
Yeah, no, nice to reconnect. You and I connected in LinkedIn in 2021, but then our paths have crossed recently, or your radar went up to talk to me because of a podcast interview that I'd done a couple of months ago with Dr. Ed Zuckerberg, who you know quite well. And Jeremy, you're now really a retired dentist. You were a dentist, practicing dentist, but now you have branched out into investing in dental technology. And you're now a managing partner at Revere. So tell us about how you've gotten to this point so far through dentistry and then out of dentistry at such a young age, and why what you're doing now is benefiting your investors and also benefiting the dental community.
Yeah, absolutely. Happy to explain a little bit more about my background and kind of the journey to this point. So there's really two parts to my background. On one side, you're right. I am now retired from clinical dentistry. I was a general dentist who practiced general dentistry as well as adult cosmetics and pediatrics for about a decade. I helped some small practices scale up to small groups, 1 to 3 locations, 1 to 5 locations, and sell. And also hold some academic roles. I have a role at the American Dental Association, the Massachusetts Dental Society. I'm the chairman of the board of a dental school. So I have this sort of clinical academic background to me. And that's what got me really linked in the space, right? I loved my childhood pediatric dentist and orthodontist and saw the way that they treated their patients and the technology that they used and the way that the business operated, and thought this was a really interesting space. Maybe it has antiquated technology, but then again, that's an opportunity, right? On the other hand, the other part of me is a startup operator. I come from tech. I had a couple exits there in web and graphic design and luxury goods and commodity services. I went on to take a leadership role later at Oscar Health Insurance, which IPO'd, and then a leadership role at Quip, the subscription electric toothbrush oral health product company, which became a VC-backed unicorn business. And so those are what got me interested in investing, right? Going through the startup process and scaling process and exit process. It's really an exciting ride. It's not for everybody, but it is an exciting ride. And so I think it's the combination of those two. I have an MBA from University of Chicago's Booth School of Business. So kind of the combined, clinical, love for clinical dentistry, love for treating patients, love for the technology that they use, and wanting to, really reform, redesign the antiquated tech that was there, as well as the kind of startup background coming from that space of building something new, building a business, building a market segment, a product market fit, and seeing it end to end through all the way to acquisition. I think it was both of those things that ultimately brought me to investing in dental technology.
It's interesting you say that. I can remember a while back, must have been about 30 years ago, a friend of my brother's and a friend of his said, I went to the dentist just recently, hadn't been for a while, and had to have a tooth pulled out. He said, and it was just so barbaric. I thought that maybe things would have changed. So we're talking 1990s. His perception from when he was a child in the 60s and 70s was that things would be better as they are in eye surgery and skin surgery, and even breast cancer treatment now is far more refined. But you're right, there's some things in dentistry where the technology hasn't caught up to the expectations of the public. How are you seeing that now? What are the areas that you're seeing advancing in dental research and dental technology?
Yeah, so agree. Dentistry often gets compared to optometry and to usually veterinary medicine, sometimes other subspecialties, but definitely those two. And what's interesting is, in some ways they're very similar. The providers and their practices act similarly. The roll-ups of their practices and consolidation in the industry has gone similarly. Some of the corporate players, the distributors, manufacturers, are actually the same in both of those, in all those industries. So we commonly get compared to them. Yes, optometrists have fancy toys, and veterinarians charge a lot of money to go into the practice, which have some similarities to dentistry, but also they're reforming their technology as well. And just a recent encounter in the optometrist's office, they now have fancier toys that can, through common optometry visits, be able to see more of the periphery of your retina. In doing so, they actually found in my eye a nevus, a freckle that is relatively large. Turns out it's totally benign. I had to go to the retina specialist in order to, an ophthalmologist, in order to properly image and diagnose that with optical coherence tomography, right? Structured light imaging of my eye. But it's only recently that the optometrist got the tools necessary to see the periphery, right? And similarly, they're using, the way that they test your eye vision by flipping lenses in order to find the right lens for your eyesight. That actually has existed for a very, very, very long time in optometry. So the reason I go into this aside on optometry is I'll kind of bring it back in full circle to dentistry, right? I went to dental school at Tufts Dental. I had got a fantastic education. On the 7th floor, you'd go into the main lecture hall every single day. And every single day you would pass right outside the main lecture hall was this large glass encasement of an 1800 style dental setup, right? Dental practice, the chair, the tools, everything, right? As if a dentist was practicing in it. And I would walk by it in and out of there every day, learning about modern day dental technology, dental materials, dental procedures. And every day I would look back out at that glass encasement as I would pass it, and I would say, those tools look oddly similar, right? They look just like what they look in the PowerPoint presentation in 1800s. How is that possible, right? It was kind of a reminder to me every single day in dental school that our technology really, it hasn't moved, that much. And so, I thought, are these really just mainstays? Is it true that, this is the way, this is still the standard of care, this is how we should be doing it? Or is it that we're truly behind, right? That research has advanced, but for whatever reason, our industry and its technology have not advanced. And the answer is kind of like optometry. Some things are still pretty old. For example, an elevator in oral surgery, some of the oral surgery tools to remove a tooth, actually still very, very similar to how they were. They're a little barbaric to the 1800s. And some of the materials are obviously a whole lot new and different. So to answer your question and to bring it back, there's a lot of new technology. Some of it is in imaging, for example, and robotics. So a company Boston-based Perceptive is able to use optical coherence tomography to see into your tooth and through the gingiva and see the finish line of the crown, even through saliva and blood, using just structured light, no ionizing radiation. right? So just like the optometrist sent me to the ophthalmologist to do OCT on my eye to visualize this nevus in my retina, same thing here now in dentistry. So you see these modern imaging techniques and robotics. This thing can plan using software and AI can plan a crown procedure. You can then send it off to have the crown fabricated or do it in your office. And then the crown can be fabricated while the robot then preps the tooth for the crown, preps it to a certain number of microns, so accurate the crown will fit. You can have the crown ready before the tooth is even cut, right? So certainly imaging and robotics has become a massive area. This area of oral systemic health integration, how the dentist becomes an integrative healthcare professional, right? Working within the medical system, using both tools and access to data that are part of the medical system, right? So oral systemic health integration and oral cancer detection and microbiome as some related subjects underneath it. That is certainly a huge area of dentistry. Interoperability, the way that our systems, even within dentistry, the way that our systems talk to one another, from pulling up an x-ray from one computer to the other, to transcribing notes from your mouth to your chart in your computer system or software system. These are all new advents as well in modern day technology. AI, there wouldn't be a technology conversation without mentioning the agentification, right? A billing agent, a booking agent, an agent for every workflow in your practice still very much need to be human guided and human supervised, right? But can make some of our processes more efficient. So these are just some of them, David. There are a tremendous number of different technologies out there, really redesigning the way that we practice dentistry today.
You've raised three things there that got my radar up, Jeremy. The robot. Let's go to the robotics on actually having the crown made before the tooth is prepped. How does a robot keep the patient still? That's where I find a difficult connection in terms of the robot operates to the preparation that's already been, the crown that's already been made. How does that happen? This is the replacement of the human being in the treatment of patients.
Yeah, it's really interesting. So a couple of things. The way this particular robot works, and there's other robots out there, right? You have Yomi by Neosis that's placing implants. You have Lupin out there in Europe doing, working on the veneer prep process, and this company Perceptive working on crown preps. Lots of different robots out there, right? I'll draw kind of the medical comparable to this, which is the Da Vinci system, right? In orthopedic surgery, they haven't actually replaced humans. They're still human guided, but they are very, very precise, right? When you need to cut something very precisely or, do a procedure that's extremely precise, the robot can calculate that and can move in a way that humans cannot, right? And so, again, they're human guided and human supervised, but they do make the workflow efficient and they do lead to some better health outcomes, right? So the way this particular robot Perceptive works is it actually has a clamp on the, within the mandible or the maxilla as it's prepping. And it does it in under 10 minutes. So 10 minutes or less, a quick prep. I've actually seen and operated this thing in a mannequin in Boston. It's also actually worked on patients, in real patients' mouths here in the United States in pilots. And even as I sit there, and I'll be honest with you, I was, kind of nudging and punching the mannequin's head. It preps, absolutely accurately. When I delivered that crown, it sat perfectly, right? So it certainly can, take into account certain movement. It does have to be human guided. So, sort of future business model, right? If the dentist is able to supervise the robot doing simple crown prep, inlay, onlay, even maybe cavities prep, then they're able to focus a little bit more on more complex cases, right? Multiple units, crown and bridge, implant, full restoration. They're able to focus their time on procedures that need much more hands-on guidance and attention, while being efficient around procedures that become pretty mundane, for the average dentist.
So watch this space in terms of robotics in dental treatment. That's exciting. It's interesting. You also mentioned about records and transference of records from one software to another. Yesterday, I had to drive 40 minutes from my home for an MRI on my lower back, and by the time I'd gotten back home on that journey, which only took 40 minutes to get home, the images were already available to me on my phone. And not only were they available to me, the report is delayed for me for 7 days, so I can't read the report, but I can share those images with whoever I want by just sending a link. So I sent the link to a friend of mine who's a neurosurgeon in Brisbane, and had a chat with him this morning about what's going on with my L4 and L5 in my spine. But it got me thinking that in dentistry, if a patient moves from one office to another, there's almost this shroud of secrecy from the departing office that they don't want to give the X-rays away, and or their physical X-rays, or there's some protection of it's not the actual image that you're looking at; it's my brain interpreting those. So, are we going to see a breakdown of that, where medical or dental records will now become easily transferable, like this radiology practice had practiced with me yesterday?
Yeah, so there's a lot of innovation in this space, quite a few problems that are being solved around, different companies taking different approaches to solve those problems. But I relate to what you're saying. Inside of even one large practice, or especially multi-site locations, right, where they're trying to really train and calibrate providers to the same quality of care, they have big problems, right? They use multiple practice management systems, multiple X-ray viewing softwares, and the way that sometimes they operate on-prem, even in the cloud, right? Their PACS system and the way that it's interoperable or not is a problem, right? They pull up an X-ray on one screen. They want one of their other practices, maybe in another location, to view the same X-ray and opine on what should be done, and they can't get the image up, right? Sometimes even within a different operatory within the same office, right, can be a similar problem. And so, that has to be solved. There are companies like Braid Health, for example, that operate in the healthcare sphere as well as in the dental sphere, and help bridge these gaps of making these types of imaging and PAC systems and information easier to exchange by basically implementing a control panel or control layer right underneath all the tech that you use, as well as solving point solutions like this PAC system problem. There's other issues here as well at hand. And, one of those issues is, what about a dental clinician accessing medical data, right? Well, it's real. I know we complain a lot about it as, dental professionals. We're sitting there saying, hey, there's a mouth and a body hanging off of it, right? And sometimes it's the medical, professional that's saying there's a body and the mouth is hanging out of it, right? Really, they're one and the same thing. The mouth is part of the body, in fact, the gateway to the body in many ways. And that doesn't mean, however, that a dental professional necessarily needs an entire lifetime of patient medical records dumped on them during the course of a dental procedure, right? It's not necessary. They do need certain information, right? They need what medical conditions this person has, what allergies they have, what medications they're currently taking, and most importantly, in a sort of a smart way, what are the interactions that they need to know? If I'm going to pull out a tooth today, I better know if the patient's on blood thinners, right? Anticoagulants. If I'm going to take a tooth out today or handle an infection, the patient's an unmanaged diabetic, I better know it because we're going to have a healing problem, right? They need to know certain relevant pieces of information. The patient is usually not necessarily healthcare literate, right? And sometimes withhold information, right? Because they think it'll somehow void the treatment that they want or cause it to be more expensive or more painful or whatever their fear is, when in reality it actually gets that way because they don't tell the truth sometimes, right? So you have this problem, and there are definitely companies working on how do we get smart medical information into the medical setting, right? Even large companies like Epic in the United States that handle a lot of the health, 250 million Americans on that platform in terms of their healthcare information. But how do we get it into dental, right? They do have a dental practice management system called Wisdom, but it's early on, right? So how are the ways that we integrate this into the world that we live in? So that's another problem. A third problem that you raised there is the issue around patients. Now, it's actually the law in the United States, not that it's necessarily enforced or followed. We hope it will be soon. But under the Cures Act here, you essentially have, this, and the ADA actually ratified this code, this section called ODIN, right, which essentially specifies what the definition of an electronic dental record is, meaning the thing that a patient has access to. Here in the U.S., we consider this MyChart, right, an acquisition by Epic, and that the healthcare profession uses to give patients digital access to this sort of universally formatted record, right? We don't have that in dental. Just like you said, the offices try to charge patients for paper and try to avoid giving it to them and discouraging it because they think it's a retention issue, right? If I give them their records, they're more likely to go somewhere else. Quite frankly, if they're trying to go somewhere else, they're going to go somewhere else, right? It doesn't matter whether or not you give them the records, right? You're just going to make them more angry, about it, and lower your overall satisfaction scores. So this is something that's being heavily worked on. There's a company called Tooth Apps out there, and it has this interconnected world of applications as well as the APIs to the practice management systems, and it's got the application for the patient built in there too, kind of the MyChart of dentistry, right? That allows the patient to have this digital dental record, right? And this is, we should be paying attention generationally, right? The young people of today, operate on self-empowerment. They want to have access to their healthcare information. They want to understand it, and they want to be self-motivated by what's going on to then act on it, right? And so we do need to understand the consumer sort of generational perspective, not just the law and what is fair, but we really need to respect both. And so that problem is being worked on today as well.
It's interesting, and leads me to that third topic that you mentioned, or that you raised in what you said a few minutes ago about the oral systemic link, and you've just mentioned it again. Is the mouth hanging out of the body, or is the body hanging out of the mouth? And there is still I believe there's still a significant proportion of dentists and doctors who believe that the mouth and the body are separate and have no connection whatsoever. And again, back in my history, I remember a learned colleague of mine just saying the things that cause people to have health issues are the same areas of neglect that cause them to have bad oral health as well, and although that is a true generalization, it's not always the case. Sometimes people can be fastidious in one part of their health, but not in others. And especially with the mouth, because the mouth is fear-related in terms of getting treatment, as opposed, some people can go to the doctor, no problem, but going to the dentist is an issue. Other people can go to plenty of people these days, Jeremy, can go to a tattooist and have needles in their skin, but they don't want them in their mouths, So
yeah, it's an interesting phenomenon. If you could imagine a patient walking down the street, and if it were a common problem that the ear would just start bleeding, right? Imagine this doesn't naturally exist. If this happens and you're listening to this, then you definitely need medical treatment, right? But imagine somebody whose ear just starts bleeding. They would never tolerate this, right? Immediately, they would go to the doctor to try to understand what is happening and stop it, right? They would step out of work. They would step out of school. They would, try to put pressure on it and clean it up. And if that didn't work, they would seek medical treatment. It would just never be tolerated. You would not walk down a hallway or sit through a lecture or anything else with blood, just a drop of blood, not enough, blood to, essentially cause a bleeding out problem, right? But, just the aesthetics of blood, right? Dripping down the side of your face like that. On the other hand, it's tolerated in the mouth. Right? People with, gingivitis, periodontitis often have bleeding gums. They actually bleed quite a bit, and they bleed all day long, right? And it's tolerated. They don't necessarily go to the dentist right away. And if anything, they try to avoid it sometimes, right? And it's interesting. That now once pain comes into the equation, don't get me wrong, right? Even the toughest of tough, when there's true dental pain, they are immediately seeking care, right? Because it's tough, right? A hot tooth, as we call it, is a tough problem. But the blood, all the lead up, right, to the pain is sort of ignored because it's in the mouth and it's dark and it's closed and other people don't necessarily know what's going on, right? Your smile, right, your front, maybe 6 or 8 teeth, sure, right, but the rest of it is really not necessarily visible to the world. So yeah, in terms of this medical dental integration, sometimes when I speak, right, what I put up is this slide that has a mouth, kind of graphic in the middle, and then it has projections to a bunch of the different medical conditions to which it is, either directly, linked or is at least correlated to, right? Coming from the bacteria, the red complex, the orange complex, the yellow complex bacteria in the mouth, right? Some of the worst players like P. gingivalis and some of the fusiform bacteria and spirochetes. There are some bad players in the mouth. And if they're, if the microbiome is in dysbiosis and is these bad players are in control in certain environments, like an anaerobic, periodontal pocket, you could be in deep trouble, right? So, what's interesting here is we have a huge business opportunity in terms of, diagnostics, in terms of preventatives, even in terms of various different treatment modalities, as well as restorative modalities. We have a ton of opportunity in the mouth that until today and until recently, we haven't really been exercising in an end-to-end pathway where we're looking at it like that. How do we prevent this? If we can't prevent it, how do we diagnose it? If we can't diagnose it, how do we treat it? And when I say treat it, I don't just mean stop it, right? But then how do we restore it, right? It is wild, right? If you say it out loud, it's a little odd to explain to a patient that the standard of care with periodontal treatment is to just cease the problem from going further. But there is no true ability to restore them to clinical health because you cannot, until recently, you cannot get the soft tissue to reattach. Even if you could get the soft tissue to reattach, until recently, you couldn't get the bone height in a pocket back. The only bone regeneration and augmentation we do is on a ridge for an implant, for example, but not in the pocket once you've lost bone due to periodontal disease, right? So these are some problems that are being worked on, and the connections to oral health, and systemic health are huge, right? Some of the most common, Alzheimer's, right, where P. gingivalis and their gingipanes crossing the blood-brain barrier, precipitating plaques in the brain. I mean, this is a huge link, right, to Alzheimer's disease, which is a massive market, by both the chronic public health nature of it, as well as the market size, the amount of money that goes into research and therapeutics and treatment and expenditure within the healthcare system. Another major one is cardiovascular disease, obviously, going especially through sublingual spaces, all the way down to the heart, endocarditis, enormous problem, all the way through to diabetes and unmanaged diabetics and pre-diabetics having a problem managing, infections in the mouth, to rheumatoid diseases, right, where inflammation is causing joint pain and problems, and bacteria in the mouth causing additional aggravating inflammation, to cancer, right, where with oral cancer, unfortunately, it is an overall, or fortunately, it is a lower incidence, right, lower prevalence of the disease, but unfortunately, we catch it only at later stages, right, where it is a huge problem to the patient. And to their prognosis and to the mortality rates. So how do we stop that from happening, right? So these are some of the major oral systemic health links, right, that are well established from a research, research perspective. We need to take it to an IP creation perspective, innovation, commercialization. And there's been some challenges in doing that, and we can certainly dig further into that as well.
Well, that's the area that started to excite me as a retired clinician, and I retired from practicing 3 years after I'd sold my practice because I've got osteoarthritis in my thumb joints, and I tolerated it in my shoulder and in my knees, but once it got into my hands, it affects how I hold things and whether I drop things. But just recently, I've become more aware through some personal involvement of, are these risk factors going to shorten my life because I ignore them? And then I relate that back to how a dentist thinks. And a lot of dentists think that these are low risk factors for the population in terms of the percentage of the population that get oral cancer. And so they're almost playing Russian roulette with their patients, not testing them and hoping that they get through their practicing life without diagnosing or seeing one. And the problem with oral cancer is that by the time it's visible, it's a very short-term death sentence and an expensive one to manage for the patient in terms of, or the government in terms of managing that patient's care from diagnosis to passing. It raises a lot of issues. So I imagine in what you do, this is an exciting time because of the ability to invest in something that's going to help save lives for people and also help to create an awareness across the board that instead of just looking at the teeth, we're looking at, do they have signs of oral cancer or do they have markers in their saliva that warn that oral cancer is more likely to occur in those patients? How does that pan out for you as a strategic investor?
Yeah, again, we have sort of problems which mean opportunities, right? One of those opportunities is, dentists moan and groan a lot about patients not coming frequently enough. We have this, just like dentistry and medicine being separated was historically an arbitrary decision. So was this come to the dentist every 6 months. And so was brush your teeth 2 minutes, right? These are all actually arbitrary, right? We've done some literature reviews and, studies now, right, that show that this is effective, but not necessarily that some other, why not come every 4 months or what about every 8, right? These were all actually arbitrary, but everybody needs a number, right? Humans operate on a plan. They need a number. And so that's largely why these things exist, right? But it's an opportunity because the patient does come to the dentist in most healthcare systems more frequently than they go to the primary care physician, right? So that allows us, if we're empowered to do so, and among other things, empowered, in terms of licensure, empowered in terms of training, empowered in terms of reimbursement or payment, right? Empowered in many ways, right? But assuming we are empowered to do so, we are able to potentially get ahead of a lot of problems, right? We can catch periodontal disease before, it affects a huge portion of the population. Adults between the ages of, roughly 45 and 64, 50% of them have periodontitis. So, and about 90% of adults, 20 to 64, have caries. So if we're able to detect these things in advance, similarly in the mouth, we can detect cancer, potentially. Similarly in the mouth, we can detect, something like diabetes or prediabetes, right? And among a variety of other metabolic disorders and so on, right? Using saliva, which contains a lot of information, then we can really get ahead of a lot of the healthcare problems that we have with a patient population that sees us more frequently. Now, the issues, right? So there are multiple issues here. One of them is the patients, from a consumer perspective, they want everything chairside. They don't want a kit with 15 steps to take home necessarily. They don't want something that's expensive. They want it cheap, right? They don't want, something that they have to wait 3 weeks for a lab result on. These are some of the, sort of hindrances to getting care done. What everybody wants are solutions that are chairside, that are quick, and that are cheap. And they also want things that are a high level of specificity and sensitivity in terms of the data output. So that's a real challenge to get solutions that meet all those criteria. Normally you get 2 or 3 of those criteria, right? It might be quick, but it's not going to be cheap, right? Or it might be quick and cheap, but it isn't going to be high sensitivity, right? It's very, very tough to get all those in a solution. So that's the innovator's challenge, right? The commercialization challenge here is even greater. I had the fortune of collaborating with the American Dental Association on oral cancer. We had an oral cancer summit in February in Chicago. And we got a lot of stakeholders around oral cancer together. The American Medical Association, the American Cancer Society, and the ADA in there, a whole bunch of the oral cancer technologies. So some of the new ones today would be Auris DX, Viome, Inotech, Proteocyte AI, right? Just to name a few that are in this space looking at interesting things. We had investors in the room like ourselves, Revere Partners. We had insurers in the room, from government and public payers to private insurance companies. We had a lot of different stakeholders. We had the providers, right? Oral surgeon group, and separate oral surgeons sitting in the room, as well as research and academics in the room. Right? Lots of the stakeholders around this problem. And what was happening essentially was, the oral cancer technology startups were sitting there saying, folks, we founded these technologies that are a product market fit. We went to regulatory, went to the FDA, we went through CE, and we got approval. We provided the necessary data to get the approval. So here you are. Here is your solution. Let's use this in the market. Let's help people. Right. And there in the room, everybody's saying, well, hold on a second. Right. First, the oral surgeons and stand up and say, I don't care what regulatory approval you have. Show me the clinical trials, double-blinded, peer-reviewed, statistically significant. Show me the clinical trials that show me the longitudinal data that this works. And the startups are sitting there saying, why are we first hearing of this? No one told us you wanted to see that or hear that. We've went and created something, right? We run on a small budget, right? We are capitalized only to do the things we say we're going to do. And we've hit those milestones. Right now you're coming up with new requirements that take years and millions of dollars to get you the answers that you want, right? And then there in the room is the investor saying, well, in order for us to invest in this thing, we need to know that the providers are going to use it and that someone's going to pay for it. And then the insurers speak up. Well, hold on a second, the dental insurer says. There's going to be a bunch of negative tests because this is a low prevalence, right? So that's a problem. And the secondary problem is any savings that are going to be achieved are savings that for the medical insurer. But we're the dental insurer, right? Why should we pay for the medical insurer's savings, right? And there sits the dental provider saying, well, we don't necessarily know how to build medical insurance. I mean, maybe the oral surgeons can do it better, but the general dentists, who are reaching all the scale of people, don't necessarily know how to bill medical insurance. They're not necessarily credentialed with the medical insurers. They are with the dental insurers. And the startup is sitting there spinning and spinning and spinning in circles, saying, we thought it was enough to create the intellectual property to solve a very challenging problem. And here are all these other public and private market problems and, frankly, market failures that we now are responsible for having to overcome in order for our thing to see the light of day. And we're not capitalized to do it. Right? So it's a real challenge. It's a complicated challenge. And it involves getting a lot of different stakeholders on the same page in order to get something like this done. So we are working on it. And we feel that there'll be a solution in the near term. But this is no easy problem to solve for an innovator.
I know with the work that I was looking at in terms of helping an oral cancer test become more prevalent in the marketplace, one of the, it's the advantage of what does the product actually do for the dental profession? And nobody seemed to be looking at the fact that a dentist who ends up with one of his regular patients having an oral cancer that was not detected, despite the fact the patient came regularly for X number of years, twice a year. And by the way, Jeremy, that down here, that twice a year to the dentist is the envy of every medical subset. The pharmacists don't get it. Nobody eats all their pills. The doctors don't get people coming back for their test results. But they say, but dentistry, people will come twice a year. Anyway.
Yeah, usually is.
That
a huge opportunity.
That horror for that dentist when one of his regulars says, hey, I've got this oral cancer and I've been seeing you and you've been looking in there and you haven't seen it, I'm going to take legal action against you. That's going to devastate that dentist. It's going to devastate his reputation in the town. He'll probably be closed down. He'll lose all his assets. He'll be sued and gone. And I think the end result is sometimes forgotten while we're talking about what the product is. In this case, it's an oral cancer test. But even in the end result of some fancy new bit of equipment, it'll do this, this, and this. But what will it really do? It'll create more time. It'll help you make more income so that you can retire earlier or you can send your kids to better schools. Sometimes we forget that end result. So what's the end result of any test that helps people to live longer? It keeps lawyers off your back. I think that's that's the scary part. The dentists say, "Oh, I just hope I don't get sued."
Yeah, and the other scary part is we don't listen enough to the consumer, right?
Yes.
I think in the United States we saw this in many other regions too. We saw the Smile Direct Club, right, which cut orthodontists right out of the loop, right, and which is not the right thing to do. And it provided care, and quite frankly, a lot of subpar care because dentists were not in the loop, right? But they were listening. They were listening to the consumers, saying, we don't want to be in the chair that much. We don't want to come back to the orthodontist. If my treatment's going to be a year, 2 years, 3 years of orthodontic treatment, I don't want to come back every 3 weeks. 4 weeks, 5 weeks, 6 weeks, too much, right? I have other things to do. I need to have treatment and not come back that frequently, right? And Smile Direct heard this and they acted, right? Now that wasn't the right way. That wasn't the right thing to do, but it also proves the point that we as a profession, one of the scary things here too, is that we don't listen enough to what the patients want or need, right? We are concerned about, our own liability and being sued. We are concerned about the kind of dental practice as a business and our own personal, financial incentives. But we also have to remember the patient, right? Maybe the patient is willing to pay out of pocket a little bit, or at least be given the choice. Hey, I can do an oral cancer screening just by looking quickly in your mouth. I can do an oral cancer screening for an additional $15, $20, $25 today, whatever it is. And I'm going to swab your mouth and stick it in this machine. And it's going to tell me if there's a likelihood that there is cancer cells in your mouth, right? Or I can give you this referral to this kit that you can do at home. You can do a spit test, send it off, and they'll send it back and tell you, right? And the patient can then have their choice. This is what's available today, right? I can't give you something that's not available or not approved, but these are the things that are an option, right? And then the choice is to them. They can decide it. I want to go through this, test kit at home or not. Right. And there's some huge really huge, I'd say great results that have occurred there. For example, with colorectal cancer and Cologuard, right. A simple home stool test has saved millions upon millions of lives, right. With early detection. So it's not to say, the mouth can't be, similarly treated through a test kit at home. Right. And so there are many companies that are doing that, oral cancer, but also microbiome. Right. If you look at Bristle Health, for example, is another, or Oral Genome, or Dentagnostics, many examples. But, similarly in the office, right, I can do it, but I'm going to charge you more, or it's going to take me an extra X number of minutes. Do you want it? Yes or no? Right. And so this is what we have today. And we should consider, whether or not the patient is willing to do this. Do they have to sit in your chair while they wait? No, send them to the waiting room. You can use your chair for another patient, right? If it's an operational throughput kind of concern in your practice. But we should really consider the patient more too.
I understand where you're coming from in that, but I found as a practicing dentist that old phrase, when the inmates are running the asylum, that's when things don't go well. And so the dental patient doesn't have a dental degree. It's the dentist's role to help the patient get the best possible treatment. So in explaining that we have choice A, B, and C, a lot of dentists just say, well, I gave them the choice and they chose actually D, which was do nothing. I gave them choices. I'm off the hook. But you're not off the hook. Down here, there was a woman who got sent to a specialist for female cancer treatment, she didn't go. By the time she did go to the specialist, she was stage 4. So she then sued her general practitioner for not following up that she had actually gone with the referral to the specialist. And she won. So the practitioner's care was that not only did he wrote everything and said, off you go, but he didn't follow up that they'd actually gone. So I think sometimes we do, and you're a practicing dentist, so Jeremy, you understand this. We say you can have a porcelain veneer. Second best choice is a composite veneer. Second best choice, composite veneers are harder to do. They take longer. They look bad more quickly, like almost as soon as they drink a coffee or a red wine, and they're cheaper. And yet they say the patient thinks, oh, second best and first best, they must be about the same, because otherwise he wouldn't recommend second and first at the same time. So I think in terms of getting the progress on these tests, because you just said it there, like the best test is the one that they've got to take home and do themselves, but it's still just get up and remember first thing in the morning, don't brush your teeth, don't eat anything, spit in the jar and it's done. And it's a lot simpler than the stool test, and I've done both, so I don't want to say I'm an expert at them, but simplicity is important. But if we could get that saliva test to be something that can be done in the chair and less expensive, but it gives you that peace of mind, I think that's important.
Yeah, I saw a stool test not too long ago that, it sounds a little gross maybe, but you essentially can wipe in the bathroom and you stick a little piece into the test, and it tells you right there if you're good or if you've got a problem pretty quickly. So it's certainly interesting if it can be done chairside and cheaply. During COVID, I think there was a lot of innovation that's now kind of gone away, but people wanting COVID tests and wanting them very quickly, and obviously with the size of problem and inconvenience COVID was causing, there were tests, right? We developed tests.
We did.
There's age-old problems, strep throat and rhinovirus, and every other disease we've all suffered from forever. Where's the test? where's the home test? I got to go to the office to get a rapid strep, right, test. There is a test. There's a home test. It's very expensive and not in mass distribution, right? But a lot of kids and a lot of parents and their work days and productivity loss could be resolved, if the kid just got on antibiotics sooner, if they knew that they had strep throat sooner versus something else. Right. So we do have, and it's true. You make a referral to the oral surgeon to get something checked out. The vast majority of people who walk out that door do not go. Right. And that's a problem. Right. And here, the way it works is you're in the US, you're supposed to technically, yes, ideally follow up, but technically you're supposed to find a provider that is available and accepts the patient's insurance. And you've confirmed that. Right. That's what's considered kind of standard of care here. It's hard to find a provider you have to essentially call in a favor. Hello, Dr. Moffet. It's Dr. Krell. I have a patient that you need to see. I'm saying so. As a favor to me, will you see this patient? They have XYZ insurance and they need to be seen today or tomorrow. Will you do it? Right. It's essentially doing that. A lot of providers, they don't necessarily do it or have the time to do it. And on the patient side, they're hearing words like cancer and oral surgeon and biopsy, right? They're hearing scary words to them, right? So it's no surprise we give them a referral and they don't do it because they're hearing pain and expense and horrible words like surgeon and biopsy and cancer. So no, they're not, some of them are scared enough to be motivated and others are scared enough to be demotivated, right, from doing anything. But then again, in Chicago, I sat down with somebody who works in the dental industry, and he had maxillofacial reconstruction, and so of course we spoke about that, and he shared kind of his cancer journey, where he just went to his general practitioner, just a general dentist for a routine visit. The general dentist said, "Have you ever had that thing there checked out?" And he said, "No." He said, "You're going to have that checked out. I want you to go see Dr. So-and-so, and I want you to see them tomorrow." right? Comes time that the nighttime of the same day, the general dentist calls that patient up. Did you make an appointment with Dr. So-and-so? No, I left a message. I couldn't get through. Okay, call back tomorrow. The general dentist calls the patient again tomorrow. Did you get a visit with, scheduled with Dr. So-and-so? Yes. Okay, great. When is that visit? And he wrote down the date and the time. Okay, let me know how that goes. Calls back the later in the day of the visit. Patient, did you go and see Dr. So-and-so today? How did that visit go? He said he needs to do a biopsy. Okay, when is a biopsy scheduled for? Scheduled for this date. Great. The dentist wrote it down, called back. I mean, literally went through the entire process where the general dentist called this guy back, and he did have a late stage and grade of cancer that needed a radical resection, of the lower jaw. And I think they took out several dozen lymph nodes, of which it had spread to 3. Luckily, they caught it in situ in I think all 3 of them. One of them was on the edge. But in addition, had to do radiation therapy and whatever else to make sure that they got it right. I mean, it was an extensive amount of treatment that this guy needed that obviously affected for a while his quality of life. But he has his life as a result of the fact that the general dentist followed and pushed up. Now, how is a general dentist practice going to do that with each of the patients? Because this guy was committed and chased it down right at 10, 15 steps along the process over a long period of time. It's difficult to do when the practice has a hard enough time answering its phones, booking its patients, checking their insurance, and getting them to come back in again for whatever. It's a challenge, and that's the space I live in, which is where we invest in these different innovators that try to solve some of these most difficult problems. And the thing from this conversation that kind of maybe puts a bow on all of it is I tell practitioners, we need you on the business side of the industry too. That doesn't mean necessarily quit your practice, right? But I get into a lot of conversations with dentists. Why don't you invest in the technology? And then you can not only capture the financial upside of it, but you can also have your direct hand in shaping what that thing is and how it needs to work, right? And so that's the world I live in with dentists, which is getting them, not just their financial upside of the technology that they rightfully, really deserve, because of the fact that they consume it, right, and that they're providing feedback on it and they're recommending it, but as a fact that it's something that they know and it's something that they can actively help improve, unlike perhaps the real estate or the CDs that they invest in, which they cannot improve, right, or nor do they necessarily know much about, right? So it's getting the dentist, I think, too, on the business side of the industry to help shape what some of these technologies can do.
It is a tough draw for a dentist, because no dentist has 100% acceptance of there are some dentists who have 100% acceptance of their treatment plan because they don't diagnose and present enough. They don't need to diagnose. But if you diagnosed everything you saw, a lot of patients put it off because it's not hurting, can't see it, and so dentists get in this. They get worn down by the rejection. And so therefore anything that could be life-threatening becomes just another thing that somebody's going to reject. And that also, Jeremy, does translate into the medical profession as well. I remember a doctor that I played golf with and telling him, patients are always asking me, can I save them money? He said, you wouldn't believe, David, it's the same in medicine. Don't you think that medicine's immune? Patients come back to me and say, have you got another heart surgeon you can recommend, because that guy you sent me to wants to charge me a bigger gap and I can't afford the gap. And I'm going, but it's their heart. And you've sent them to the best person that you know to do it. And he goes, they are like that. And then I remember another dentist friend of mine from the Midwest telling me, he said, we have a hard time convincing patients about what's going on in here when they don't even care how they look on the outside, and their belief is, well, I've paid my taxes. It's up to the government to keep me alive if something goes wrong. And prevention is in the mirror. The answer is always in the mirror. What did I do to prevent how I am now? And the progression of the obesity chart of the United States. It's now all totally dark blue. Every state is overweight, and weight is directly related to less optimal health. So
until they believe a miracle pill comes along.
Oh, that's right.
Like glyphosate, Wegovy, right? Just look at this, right? I can take a pill, it goes away, I'll be healthy again, right? And I'm sitting here saying, what's the long-term effects of that? Did anybody know? Right? On top of that, why do you think that losing weight replaces cardiac health? You still have to exercise in order to get the health benefits of exercising. It's not just losing the weight, right?
Yes. Yeah, yeah. There's a pill for males that's been out a while now too. The high risk cardiac incident doesn't seem to bother some guys. Anyway, Jeremy, this is an exciting topic, and it's a topic that will be around forever because there's always problems to solve in the health industry, in the health profession. The longer people live, you touched on Alzheimer's, and that's affecting more and more people. When I graduated as a dentist, if somebody lived to the age of 65, their last dental appointment was to get a new set of dentures before they retired, and they were usually dead before the 7 years was up for their next set of dentures. Now, I was fortunate to practice on baby boomers, and what I said was we need to superannuate your teeth so that dentistry is not an expense in your retirement. You need to fix them now while you've got an income, not retire and go, oh, well, I haven't budgeted for it. So it's always going to be there. How can people get in touch with you and with Revere Partners, Jeremy, to learn more and possibly become an investor or somebody who can help in terms of at the grassroots level, in terms of, as you mentioned, being on the side of the patient to take action rather than ignore? How can somebody get in touch with you?
Yeah, so you can get in touch with me you can first of all visit our website at reverepartnersvc.com. You can get in touch with me at my email, Jeremy, Jeremy, at reverepartnersvc.com. And as you mentioned, we founded Revere Partners, which is now an institutional VC fund for dental technology by doctor for doctor. So we very much encourage doctors being both invested in the fund as well as getting involved in helping advise us on diligencing these companies, as well as getting involved in advising the companies directly. So it's very, very much industry oriented and clinical and clinician oriented what we do here. So please do reach out and visit me and email at jeremy@reverepartnersvc.com.
Now, Jeremy, this podcast goes to other countries in the world, like third world countries like Australia as well. The dollar's worth only 60 cents. Is it easy for foreign investors to invest with Revere?
Yeah, actually it is for the vast majority of countries out there. Revere is global in both our investors and investments. About 65, I'd say, % is North America focused. About 35% is global. So investors and investments all over the world participate in Revere. So no problem. And if there are questions, certainly we can answer them.
Dr. Jeremy Krell, thank you for your time tonight. And thank you for being a guest on the Ultimate Dental Podcast. Really appreciate your time. Thanks, Jeremy.
Thank you for tuning in to another inspiring episode of the Ultimate Dental Podcast. We appreciate each and every one of you for being a part of our dental community and joining us each week on this incredible journey. If you found value in today's episode and you don't want to miss out on future episodes packed with expert insights and actionable strategies, here's how you can stay connected with us. Firstly, hit that subscribe button. Whether you're listening on your favorite podcast platform or watching on our website, subscribing ensures you'll never miss an episode. Secondly, share the love. If you know a fellow dentist or colleague who could benefit from the wisdom and knowledge that we share here, please share our podcast with them. Also, please share the podcast on your socials by simply clicking on the social icons wherever you view or listen to this podcast. Together, we can all do our bit to elevate the dental profession. And finally, stay engaged with us. We love hearing from you. Your questions, comments, and feedback fuel our mission to provide the best content for your professional growth, your personal growth, and for your practice growth. Remember, your journey to creating a dental practice and a business life that you love is our mission, and we're excited to be your trusted guide along the way. Thank you for being a part of the Ultimate Dental Podcast. Until next time, keep smiling, keep striving, and keep on tuning in to the Ultimate Dental Podcast.